we're going to look at a minor oral nasal fistula repair in a dachshund who had the left maxillary canine tooth extracted, initial closure, and then 2 additional attempts to close his fistula, which were both unsuccessful. The second was they achieved a little bit more closure than on the first attempt, but you can see there's still a fistula there. And I think there are 3 reasons why these fail. 1 is because there's tension. 2 is because the patient gets to the area and causes trauma and disruption of the suture line. And the 3rd, we're resolving here. Now what we're doing is we're using a fine diamond tapered burr, and we're removing the epithelium around the palatal mucosa, and then we're going to do the same gently to the alveolar mucosa that's dorsal there in the video, that's attached to the bone underneath. So that's what we're doing right now. We're just taking and we're removing very gently a millimeter or so of epithelium, so that when healing starts, that epithelium won't have an opportunity to migrate down into the area between the 2 edges that we're going to suture together, being the mucosa and the palatal mucosa, in time to cause that not to heal. So I think that's one of the biggest reasons why these things don't heal, with the exception of tension, is because we fail to do that. So that with that complete, 360 around that lesion, now what we're going to do is we're going to just take a scalpel and just incise the area adjacent to the underlying bone. And then once we've done that, we've created a path for our periosteal elevator to go all the way down to the bone to start to elevate that mucosa off the bone. Now, you're going to have a lot thicker tissue there than you would normally if you were doing an extraction, because that fibrous tissue's had a chance to organize and adhere to that underlying bone. So what I like to do is get that fibrous tissue off. It's much easier to get that elevator down there and really put some good pressure on it, as you see we've done, and then come back and dissect the mucosa from that underlying tissue to give it more resiliency. So what we're doing right now is we're using that periosteal elevator, the larger end, and getting a little bit more aggressive there. Now we've got that open, and we'll take and incise that thick granulation tissue, or actually fibrous tissue, off of the palatal aspect of that mucosa, trim it away, and create a nice flap that has no tension prior to closure. So you see we're doing that there. We're going in the mucosa interface between that mucosa and that fibrous tissue, and now we're just going to cut right along that margin and start to disrupt that communication between those 2 tissues. And then as we progress, what we're going to do is, as we're doing here, we're going to trim away that thick tissue, create a nice margin at the edge there to be able to suture back. And there we go, we're trimming that away. I'm going to trim that away, make it nice and resilient, make that tissue nice and mobile, so that we can suture it back. And again, the key here is no tension. So you see we're getting pretty aggressive there, right underneath that fibrous tissue. There's a little bit of it there coming through. We're going to clip that, and now we've got a nice resilient flap that we can suture back to that palatal mucosa. And again, we've got that little 1 millimeter or so margin where we've taken that epithelium off, and now we've got connective tissue underneath that will allow us to have a zone that will facilitate healing and not have to worry about that epithelium migrating into the area between the edge of the mucosa and the palatal mucosa. So there's our defect that we've created. You can see there's some hemorrhage, but it's minor. It's not anything that you need to be concerned with other than visualization. So there's a small vertical component on all of these in the back, and so you want to suture that vertical component going distal to mesial, and then once you've done that, then you can start on the actual suture line down at the palatal mucosa. Now we proceed up to the next location, and you want to take big bites here. There's no reason to be conservative as far as the bites go. You want nice big bites in the palatal mucosa, in the vestibular mucosa, and then simple interrupted sutures all the way through. We do a double pass around the pickups for our first with 2 throws, tie that, and then go back 2 single throws again. So a surgeon's knot and then two single throws, tie all 3 of those, and we're ready to go. We use 4-aught monocryl for these. If it's a really large dog, we might use 3-aught, but not really commonly. So 4-aught, if you've got a really small dog, certainly could consider 5-aught monocryl, but they do quite well with 4-aught. Now here we're progressing forward. You can see there's no tension on that. There's a little vertical component there as well. So we go in, then into the mucosa and tie that, and that will complete the procedure. Now, one thing that you need to keep in mind, one of the things that I said that could result in failure here is the patient getting to the area with their paws or rubbing their face on the floor. So you always want to use an Elizabethan collar and discharge that with 2 weeks minimum, possibly 3 weeks for the dog to wear, and make sure that the owner knows that the only way that this is going to fail is if the dog gets to it. So there you have it.